Hello and welcome to Cromwell Hospital's latest online health talk on navigating endometriosis pain. Please ask your questions using our chat function. Our panel will try and answer as many as possible before the end of the webinar. This webinar is being recorded and you will be sent the recording tomorrow morning. Please be aware that we will be sharing a few images and a video of surgery during the session. I'd now like to welcome Mr. Amer Raza, Consultant Gynaecologist, Dr. Norman Kufakwaro, Consultant in Anaesthetics and Pain Medicine, and Sharon McVeigh, Cognitive Behavioural Psychotherapist, your panel for this online talk.
I thank you very much, Hattie, for introducing. Let me share my screen with you and then we will start from there. Thank you for everyone to join us. I know how busy we all can be. And so many of you joined, so thank you very much. Can you see my screen? Can somebody just confirm to me, please? Hattie, can you see my screen?
Yes, we can see your screen, thank you.
You can see it, thank you. Thank you very much, and thank you everyone who is here, who joined us for this very important topic, which, to be honest, even though I do endometriosis every day, but I'm myself looking forward to share, learn things from our colleagues about pelvic pain. Pelvic pain is a very challenging area, and I think it's beyond endometriosis. Endometriosis, at times, we can remove it, we can excise it, but still the pain carries on. Pain is such a single, most important and the powerful factor which can have a huge impact on one's quality of life and the normality of life as well. So it's a great opportunity for us, all of us, to share. We will absolutely be listening from you as well through your questions, which we'll send to Hattie. And we'll be listening to my very good colleague, Dr. Norman Kufakwaro. Dr. Norman Kufakwaro is a very well-known chronic pain specialist. His expertise goes beyond endometriosis, helping with patients with spinal diseases and chronic problems. And he is integral part of endometriosis team, that when the pain becomes excessive, doesn't get better after surgery or other complex matter like involving nerves, then we need his help. And he's absolutely a great asset to our multidisciplinary team in Cromwell Hospital. And Norman, can I ask you just to introduce yourself as well, a few words about you, please?
Thank you very much, Amer. I'm Norman, Dr. Norman Kufakwaro. I'm a consultant in pain management. I work very closely with Mr. Raza in looking after patients with complex pelvic pain. In addition to that, I also specialize in spinal pain, chronic widespread pain, and cancer pain as well. So I'm really looking forward to this webinar. We've done quite a bit of work together in the multidisciplinary team that we run out of Cromwell Hospital with Sharon as well as our psychologist.
Thank you very much, Norman. And then we will be joined by Sharon. Whenever the history of pain starts, it has a huge impact on one's psychological health, mental well-being. It is a massive drain on not only patients on themselves, but the people around them as well, the parents, relatives, friends, family. And it's difficult to have this journey alone with this severe pain. And here comes Sharon with absolute expertise in helping people with the mental well-being. Sharon, would you kindly introduce yourself and exactly what you do and how you're part of this team?
Yeah. My name is Sharon McVeigh. I'm a cognitive behavioural psychotherapist. And, you know, I've been working with clients with long-term conditions for nearly 6 years, but in mental health for over 25, complex mental health. So, and by the time we see the clients come to us, they've been, like what Dr. Raza is saying, through many years of, you know, pain, you know, impacting their life in every aspect of their life, school, work, family, relationships. So by the time they come to us, the psychological impact is quite significant. Low mood, anxiety, social anxiety, being afraid to go out to different places. So yeah, when they come to us, it's about helping you start to see that there is someone here that will listen to you, for a space for you to tell your story. And that's where I come in with the team.
Thank you very much, Sharon. So look, what I'm going to do for the next 5 to 7 minutes, let me take you through endometriosis. I should warn that I'll be sharing 2 videos of operations showing endometriosis. I will warn you before that slide start. Please stop the video if you don't want to watch. You can just listen to me, and when the video is over, you will always can join us back as well. So let me share my screen with you now, and I will take you some fundamental concepts of endometriosis before we go into the world of pain as well. So can you please see my screen? Can somebody confirm?
We can see your screen. Thank you.
Thank you. So endometriosis pain is a very significant and massive problem. And we know how big the problem is. Many of you possibly are having it, suffering with it, or have someone in your family, friends who suffers with the problem. It's a huge number of women. 10% of women, 250 million women suffer with this problem. No diagnostic test. That's the sad story of this whole thing. We do not have a single test by which we can tell you that you have endometriosis or not. Yes, history, examination, ultrasound scan, MRI scan can help to give you a good idea that you have endometriosis, and we're getting better and better with it, but there's no single test. There's a lot of talk of genetic tests, but I think still we're at early stage to recommend to all of our patients and customers. Thirdly, there's no cure for the problem. Even if I've diagnosed endometriosis, yes, I can excise it. I can give a medical treatment to suppress it. But is there a cure where I can give some injection, some treatment, it goes away? No, there's no cure to it as well. And the issue of endometriosis is so huge that it spans right from quality of life, such as pelvic pains, period pains, and all problem which comes with it, all the way to fertility, which again can be a very significant issue, especially when ovaries are involved, leading to low AMH results at a very young age, as young as 20 and 25. It's a multi-organ disease. It's not something that is sitting in one structure like uterus or liver or spleen. No, it comes out of the uterus, around the uterus, involving ovaries, fallopian tube, rectum, bowel, going into nerves, going all the way to diaphragm. It is a disease which absolutely extends itself, which makes it a more challenging as well. And really, from a normal life, things can go towards depression and anxiety. So this problem has many, many challenges. And all of you who have endometriosis and suffered yourself as well, there's a delayed diagnosis. We have a huge number which have an issue with the fertility now. And there's a huge lack of awareness and lack of research. However, I paint this picture, but things are changing, they're getting better, and we're all moving forward with some good news, which we share with you in these webinars time to time again. But it is a challenge because of all this problem. I call it is etiological confusion. We don't know where this disease is coming from, and the therapeutic anarchy. If we do not know where it's coming from, how can we treat it more effectively? And that's where the more challenge comes in and more questions come into place as well. When we look at this disease, it can involve the bowel. There's a 35 to 40% overlap with bowel issues, either bloating or those things. Number of gynecological issues, from painful period, dyspareunia, painful intercourse, to pain throughout the month when things get severe and worse. Musculoskeletal pain, urological pain. And I can go on to say how many systems this disease can have an impact on. But when it comes to pain, we also see a very typical thing about endometriosis, and that is it's a chronic inflammatory condition. It involves bladders. This inflammation which comes out of endometriotic deposits, which I will share with you in the next screen. These lesions, these small nodules of endometriosis, this inflammation of inside peritoneum goes on to involve all the structures around. It will involve the bladder. Irritable bowel, interstitial cystitis is a very well-known problem. Or irritable bowel syndrome can happen. So there is something goes on in this disease which increases the inflammation and involves number of structure. And then it involves the sensory system, the neurological system, where Norman will tell us more about how it involves those structures, causing from simple pain to very chronic and resistant pain. But then it also looks like that these lesions are just more than it, because there will be time when I will remove these lesions, but still people will be in pain. So if you don't switch off the screen, switch off screen now, because I'm going to go through a video in which I will show you different types of endometriotic lesion. So you exactly understand when we use the word endometriosis, what does it mean? So we go into video now. So this patient has endometriosis. You can see now we are behind the uterus. On top of the screen, we have a uterus. On the left side, you see white left ovary, left fallopian tube. And look at this yellow area and red area. These all endometriosis are these black nodules of endometriosis. It's actually the bowel you see now, which is going into back passage. And all this area is now full of endometriosis. However, this is a superficial peritoneal endometriosis, and it comes in so many colors. It has got small white spots, but these are the areas which cause pain. And if I just stop my video for a second, and again, I'm sure that Norman will tell us more. You look at these fibers running along. These fibers actually are called part of the inferior hypogastric nerves. These nerves supply bladder. These nerves supply bowel. They supply the vagina and vulval area. So if disease involves these areas on the pelvic side wall, you can see how close the nerves are. And once they involve the nerves, endometriosis doesn't have to be in the bladder. As long as it involves these nerves are supplying the bladder. So I may have a bladder symptom like pain while passing urine. My bladder fills up, I have pain. Those pain symptoms will be at the bladder end, but actually the problem will be starting right from here. So this video kind of gives you an idea that how it happens as well. And then keep seeing, I will show you. And look at this one now. This is again another big plaque of endometriosis on the left uterosacral ligament. This is the most common place where we have endometriosis, is the arch actually, and the endometriosis is on the right side as well. And you may hear pathologies, but I will not go there. And just here we can see same area where the nerves are getting involved as well. That's the bowel and the rectum. And you can see how the rectum and bowel is all endometriosis is involved in the bowel as well. So when we say your endometriosis or the bowel is tethered with the back of the uterus, that's exactly what we mean. And this is the area which actually will have nerves involving in them from where the pain and symptom will come in. I'll just go forward quickly because not much enough time, and that's exactly what we remove, but I will move on from there as well because the purpose is not to show you the video, but I will show you the pathology of the disease, what it looks like. And this picture shows you, when I used the word just last video showing you there's an inferior hypogastric nerve, you can see now that these nerves are coming from the vertebrae. They're creating small complexes putting together, and from there they're supplying different structures causing pain. So problem could be in one place, but pain can be in the other place. That's the fact in endometriosis. There are so many mechanisms by which pain can be explained. There are a lot of factors such as prostaglandin, prostacyclins, interleukins, which go high up. These are the inflammatory cells which go high up in the peritoneum, which I showed you just now, and that one creates the environment from where the pain comes. And obviously nerves are one of the most common areas. This is the case where we are actually dissecting the right pelvic sidewall to get to the sciatic nerve, the S2, S3, which actually can transmit the pain in the pelvis as well. So this is very deep structure now. And we have sciatic nerve running right this area where they supply this area as well, where endometriosis can grow, and this pain can become a shooting pain going down to the legs and radiating down to the legs. Not only this, these nerves supply bladder, another thing as well, and you can see nerves lying down exactly here by other areas as well. So this big challenge that this disease, which is deep, hidden, brings a lot of surgical challenges, how to treat it. And this complexity is the one actually which then brings us to people like Norman to help us to understand this pain better. So I'll stop sharing it now. I didn't go towards management because that would come toward the discussion. I will let Norman take the baton from this point, that how this pain transmits and what does it do with us. Norman.
Okay, thank you very much, Amer.
Hattie.
Thank you. Thank you very much, Amer, for your presentation. I'm going to talk about how endometriosis leads to persistent pain. Next slide, please. So what happens when you refer to the pain clinic is we tend to take a very comprehensive history, because I always tell my registrars or my junior doctors that it's very easy to establish a diagnosis if you get a very good history, and then that will lead you to a targeted physical examination and try and find out where the pain is actually emanating from. As my colleague has just mentioned, you've had your laparoscopy, the endometriosis has been taken out, but you've got persistent pain. The question now is what's really going on? This is where now we look at what we call, the pelvic pain syndrome or endometriosis associated pain. But just like the slide we've seen just now, there are a lot of organs are in the pelvis and around the pelvis, which can lead to pain as well. So if there are any bladder issues, you be referred to see a urologist. And if there are any gastroenterology problems, you will refer to gastroenterologist. And sometimes we may see that some patients may have pain emanating from the back, leading to pelvic pain, where you've got some disc prolapses or nerve root compression, which you then need input from neurology, neurosurgery, or spinal surgeons. And then in most patients, we see that there's problems with the pelvic floor, where there may be weakness or hypertonic muscles, and that usually we refer all these patients to our physiotherapy. So next slide, please. So how does acute pain, become chronic pain? In most people, when you've got pain, say coming from endometriosis or in the pelvis, if you have had the operation within 3 months, everything would have settled. We see a cohort of patients that have persistent pain after they've had their surgery. The reason being is there is a genetic contribution where some people are prone to developing chronic pain, and others may be associated with psychological issues like stress, where there's increased secretion of hormones like cortisol and reduction of endorphins, which predisposes you to chronic pain. And also it may be recurrent somatic irritation inside the pelvis from scar tissue or adhesions. So eventually what that leads to is a peripheral nerve injury or peripheral nerve sensitization. And then you get what we call peripheral afferent signaling, which leads to central sensitization. Central sensitization essentially means that the nerves that carry pain have become very sensitive, which means you tend to feel pain very easily. So even wearing tight clothes can lead to pain. So once this has happened, we tend to call this kind of pain neuropathic pain. And the unfortunate thing about the nerves in the pelvis is that they communicate with the surrounding nerves due to convergence of the nerve pathways in the spinal cord. So you may realize that you've got pain in your pelvis, but you started developing some lower abdominal pain as well, which is what we call visceral hyperalgesia. In addition to that, there's also something that we call visceral somatic hyperalgesia, where communication of the organs in the pelvis and the surrounding muscles leads to increase in muscle tone. And sometimes that can be associated with effects on the sympathetic nervous system or the parasympathetic nervous system, which is what we call the autonomic nervous system. Next slide, please. So there's this condition we call endometriosis-associated pain syndrome, which is chronic and recurrent. And in most patients, they come to the clinic and say, "Doctor, yes, I understood I had endometriosis, but I've had my operation, everything is, is been taken out. Why am I still in pain?" I always highlight to patients that what we see on imaging or what you see on laparoscopy is no bearing sometimes to the severity of the pain that one experiences. The reason being, the genetic component that I mentioned earlier, and also, psychology plays a very big role, which Sharon is going to talk about later on. So once you've had this pain for more than 3 months, like I mentioned, it becomes chronic pain where you've developed negative cognitive, behavioral, sexual, or emotional consequences as a result of the ongoing pain. And then you get associated symptoms involving your bladder, sexual, bowel, and also gynecological dysfunction. So I just wanted to highlight a few conditions, a triad of conditions, that I've noticed, especially in young female patients with persistent pain are associated with endometriosis. Like Amer mentioned, it's a very difficult condition to treat. And, I've had to dig a bit deeper to see what else could be associated, what else could be going on. So the conditions that I see commonly associated with persistent pelvic pain, especially in endometriosis, are Ehlers-Danlos syndrome, / what we call hypermobility, spectrum disorders, and mast cell activation syndrome, as well as dysautonomia and POTS. So I'll talk about these conditions one at a time. So Ehlers-Danlos syndrome is where you've got an issue with connective tissue. The main problem being very weak connective tissue, leading to weak core stabilization. And as a result, you end up with hypertonic pelvic muscles and overactive pelvic floor muscles. And when that happens, normally that sort of cuts pressure, within the blood vessels, and also increases pressure around the nerves that travel throughout the pelvis. That can lead to chronic pain from both anaerobic, respiration due to buildup of lactic acid, and also pressure within the nerves that travel within the pelvis. Then one common condition I tend to see as well is hypermobile joints, because most patients that come to my clinic, I tend to request MRI scan of the spine, including the pelvis, and also looking at the hip joints. I've noticed that a lot of patients with hip labral tears, which are generally managed conservatively by my orthopedic colleagues, can lead to persistent pelvic pain. What happens is you get spasms of the obturator internus muscle, which then compresses the pudendal nerve, and that can cause deep-seated pelvic pain. In addition to this, we know that Ehlers-Danlos syndrome can lead to sacroiliac joint instability or disc prolapse, or sometimes talus cysts, which can lead to irritation of our nerve roots as well. In addition to this, a lot of patients with Ehlers-Danlos syndrome tend to be prone to pelvic congestion syndrome. So I usually do a full workup with MRI scans of the pelvis, lumbar spine, and also nerve conduction studies to ensure that there's no nerve root compression, which could be contributing to persistent pain. The next condition is what we call MCAS. I'm not sure if a lot of you have heard about this condition. It's essentially mast cell activation syndrome. We know that mast cells play a very important role in inflammation, but there are some people that have this syndrome where mast cells release nerve growth factors and another chemical called heparinase. What it does is triggers proliferation of nerves within the pelvis and makes them generally very sensitive. So if you combine this with endometriosis, where you've got lesions irritating the nerves already, and also you've got scarring and adhesions, you end up with sprouting of pain fibers, which are responsible for deep-seated pelvic pain, burning, sharp pain, and sometimes just dull, achy pain. In addition to this, the heparinase, what it does is it allows the pain fibers to perforate the basement membrane, which means that the pain fibers or the pain receptors become more superficial. This generally leads to the skin in the perineal area becoming sensitive, which is a condition that we call allodynia. And also, endometriosis is associated with painful bladder syndrome, or sometimes irritable bowel syndrome, which is where you'd get pain within the pelvis as well as lower abdomen. The next condition is dysautonomia. Dysautonomia is essentially a condition where the autonomic nervous system is not working very well. And we've noticed that, and there's emerging evidence that it's also associated with endometriosis. The basic problem being the disruption in circulation tends to negatively impact the autonomic nervous system, which then exacerbates the symptoms of pelvic pain, including urinary symptoms, as well as gastrointestinal discomfort. Eventually, what happens now is we end up with a group of patients that are very sensitive to pain, where you get heightened sensitivity to pain. And in terms of pain management, what happens when you come to the clinic, we appreciate that this condition is difficult to treat, so we tend to operate as a multidisciplinary team. You would have seen my colleague, Mr. Raza, and then eventually you come to my clinic with persistent pain. And I tend to assume a holistic approach due to the biopsychosocial model of pain. So this incorporates physiotherapy, which most patients would have gone through already in terms of pelvic physiotherapy, as well as psychology. Normally, I would refer patients to Sharon for things like cognitive behavior therapy, as well as acceptance and commitment therapy. With regards to pain medicine, there are a few options that we can offer you. We usually start with simple analgesics, things like paracetamol, non-steroidal anti-inflammatories. If these are inadequate, then we escalate your treatment to what we call chemical neuromodulators. The chemical neuromodulators are medications that are designed to alter the way the nerves work. Remember, I mentioned that the primary problem is that the nerves generally become very sensitive. So we're trying to reset the nerves to get them closer to normal as much as possible. You may have heard of medications like amitriptyline, gabapentin, pregabalin, or sometimes duloxetine. The other option is what we call topiceuticals. These are creams that can be used topically, like non-steroidal anti-inflammatories, and also some local anesthetics. In addition to this, there are a few pharmacies now that are compounding the chemical neuromodulators, which are mixing, gabapentin, amitriptyline, or pregabalin with amitriptyline, which can be used as topical creams. And then the other drugs that I tend to use most of the time in my clinic are antispasmodics. Remember, I mentioned that with chronic pelvic pain, you tend to get, hypertonic pelvic muscles. So there are some oral antispasmodics that we use, which include medications like baclofen, tizanidine, as well as methocarbamol. If this is inadequate, I tend to undertake intramuscular injection of Botox, especially into the obturator internus or the pelvic floor. This is something that is done under ultrasound guidance. I must say, I've seen a lot of patients do very well with this procedure. If all this is not successful, then we'll proceed to try some interventions. The interventions include diagnostic nerve blocks, which would include things like pudendal nerve blocks, the hypogastric plexus, which plays a very important role in transmission of pain in the pelvis, or ganglion impulse block as well. If there is a favorable outcome following these interventions, we usually consider radiofrequency, where we use radio waves to alter the way the nerves work. Essentially, what's happening is they're trying to reset the nerves to get them closer to normal so that you can gain control over the pain. However, all these procedures, sometimes they're not successful. You may have heard of neuromodulation, which is a neurostimulation, where we use some electrical leads to stimulate the peripheral nerve receptors. It can be done either transcutaneous or percutaneous, or we can also do sacral neuromodulation. However, there is emerging evidence that there is a newer technique which is currently being practiced in Europe, where we put, where there is laparoscopic implantation of leads around the sacral plexus. We are hoping to bring this to Cromwell very soon. Yeah, I've got a lead here, a slide here just to show you, the procedure. I think you can see the lead in circle, which has been circled there. If you can move on to the next slide, which is much clearer. Yeah, you can clearly see the lead lying next to the sacral nerve roots. This is a procedure which is done laparoscopically, and it's a multidisciplinary procedure involving gynecologists, pain physicians, and neurosurgeons. It's a promising procedure in the sense that we are placing the nerves directly where the issue is, and it's connected to a pacemaker, which will help you to gain control of the pain. Thank you very much for that. I will hand you over to Sharon.
Thank you.
Thank you. Thank you. That was very interesting. So let me just. Oh, sorry. Share the room. Bear with me. It will work.
Wait.
Yeah.
Put
Yeah.
presentation.
Can you see? Can you see it? Okay.
If you can see the presentation mode from the bottom.
Yeah.
Screen will get bigger. Just presentation mode on the bottom.
Okay. That it?
That's fine. Amazing. Thank you.
Yeah. Okay. So, bear with me. I can't see you guys now. but you know, like what Dr. Raza and Dr. Norman have said, by the time you've gone through all of this, you know, it's probably been many, many years. By the time you've got diagnosed, it's exhausting. And what we can see from NHS research is that approximately 2/3 of people with long-term physical health conditions also have comorbid mental health difficulty, mostly depression and anxiety. And 70% of people with persistent physical symptoms such as pain have anxiety or depression. So the necessity for psychological support is huge, but unfortunately it's not that accessible either, you know. So when you come to, you know, having some psychological therapy, sometimes there's a barrier about how people feel about that as well. So hopefully this will help you see that, you know, coming to treatment is going to be somewhere for you guys to come and just tell your story. You know, we do the assessment and the treatment to allow for, you know, the long-standing nature of the condition and the impact it has had on your life. You know, the impact of the illness includes such things as reduced activity, difficult thoughts, the impact on your emotions, you know, the feeling of loss, you know, the unpleasant body sensations, memories. So initially what we'll do is we'll just take some time to listen to that, because a lot of you have probably spent most of your time just trying to be seen or heard or listen, you know, get someone to listen, you know. And also the anxiety and the depression is just part of it. The pain, you know, the fatigue, the sickness, we look at how this has impacted your life, from your relationships, your work, social situations, studying, you know, personal activities, physical activities. So we look holistically. And a big thing with the cognitive behavioral therapy or any psychotherapy for long-term condition or endometriosis in particular is that, you know, we can't change the physical condition when you come for treatment with us. You know, we leave that to the medical staff, but we class that as primary suffering. And a lot of the time what happens is people are trying to fight against the condition, you know, and they're in a bit of a tug of war with themselves. So what we want to look at is the secondary suffering, that impact that it has had, the emotional suffering, feeling like you're not living a valued life, the impact it has on, you know, your identity, you know, who you thought you were, you know, that the maybe not being afraid to, or being afraid to say what you're going through in work, you know. For a lot of women, they struggle on through it and feel that they have to work even harder. So they're constantly in this battle. So you come physically and emotionally exhausted. And so this is an opportunity for us then to look at what we can do. We can use the CBT for the depression and anxiety, looking at the challenge and thinking the really difficult thoughts about yourself, the world and others, learning how to be compassionate to yourself, you know, filling your own cup, like I've said here. You adding value back into your life, you know. Sometimes, unfortunately, what happens is we feel like we have to solve the problem, and then that ends up that we're constantly with the problem and we forget what we enjoy in life. So starting to get a little bit of that back into your life as well. Learning how to prioritize your needs, both physically and mentally, because some people, they might have families or they have big responsibility and job, and they will put all of that before themselves. Again, the stress, low mood, anxiety, feeling like you can't fulfill your position. And we look at the energy in versus energy out. We call it boom and bust. You know, many of you, you know, will be experiencing pain, maybe bleeding, you know, you maybe have had surgery, but you try to keep going, keep going, and keep going. So we look at the boom and bust cycle, you know, that we try, but then we come down further. Days where we feel we've got energy, you try to do more than what you can, and you come down again. And then we end up fighting with ourselves, and then feeling like, you know, we're not good enough, or we can't do it, or, you know, feeling a little hopeless. That's what the psychological support is about as well. And also assertive communication, you know, learning how to be a little more assertive about your needs without feeling guilty or feeling that people won't understand. Other interventions is we use some imagery, mindfulness, progressive muscle relaxation, a bit like what Dr. Norman was talking about. The tension in our body can lead to a very strong muscular response. So we try to bring some relaxation in. We work on sleep hygiene, the pain gate theory. We look at that as well, and the history and how the cognitive function of our memory works with pain as well. For example, maybe someone has been to an event and they had a lot of pain, experienced a lot of pain, they left it. So then next time they have a family event, the thought of that is difficult, and the memory of what happened before comes in. So we look at all of that and try to break some of that down and help you start to live alongside the problem rather than you trying to constantly fix it or solve it, living alongside the pain. And that's me in terms of my
Thank you, Sharon. Yeah, carry on. Thank you very much, Sharon. Okay, back to Hattie.
Hello, would you like me to ask you some questions?
So first of all, let's take it from there. So thank you very much, Norman, and thank you very much, Sharon, as well, to put things in the context. Many of you will be watching, and I can see lots of questions have been placed as well. I don't think we'll be able to answer all the questions, but we'll try to answer questions among ourselves as many we can. And then the rest of the questions, we will send them to our specialist nurse, Janaya, who possibly will consult with us and will send you some questions and answers by email. So Hattie will ask the question, one of us will choose who will answer, and then we'll try to answer as many questions as possible. But as you can see, it's a very complex problem. Sometimes as surgeon, I wonder that if it's like somebody comes to my theater for appendectomy, for example, we take the appendix out, problem is sorted. When it comes to endometriosis, it is not that simple. I can go in surgically and remove that lesions I showed you just now, the black lesions. And even if I have removed all those lesions, cleaned the whole pelvis, there'll be still 15 to 20% of people who will come back to me, they have pain. And that's where we think this is much more than this endometriotic lesion, what we surgeons go see and cut out. It's more than that. And then it comes back to exactly what Norman told us, different pathophysiological systems by which the pains and pain perception and nerve changes, and this thing becomes much complex than simple nodule what a surgeon has to excise. Okay, with that small pretext, Hattie, please go ahead with the questions and we'll try to answer them. Thank you.
Thank you. So the first question is, can exercise help manage pain, and should I exercise when I'm in pain?
Norman, you want to have any comment on this one?
Yeah. Generally, we encourage exercise. Remember, I said that a lot of patients have got very tense and hypertonic pelvic muscles. So pelvic physiotherapy will help to loosen those pelvic muscles. But sometimes I see that some patients that have had this pain for quite some time, the pelvic muscles or the obturator antennas becomes like a very tight rubber. which is where you get to the point where even, exercise or physio tends to aggravate the pain. For that group of patients, I always say it may be best to try intramuscular injection of Botox first to loosen the muscle, and then you can, engage with exercise and physiotherapy after that.
Right. I mean, the one thing I learned from physiotherapist colleague as well, in addition to that, is when it comes to endometriosis and pelvic pain and exercise, high intensity exercises are usually not very good. It is the exercises like reformer Pilates or yoga where you learn to relax your pelvic floor muscles. They are much better when it comes to endometriosis. Thank you.
Will an anti-inflammatory diet help keep the pain away?
Any comment?
Yes, generally for chronic, chronic pain or chronic pelvic pain, we do recommend that people go on an anti-inflammatory diet. But for most people that eat a healthy and balanced diet, this normally, incorporates everything that they need to eat. But when you look at this disease, it's quite complex, and I see a lot of patients who eat well but still struggle with pain, which is where we escalate and start looking at the drugs that I was talking about, which are the chemical neuromodulators, and the various interventions that we do, and also trying to exclude other associated conditions which can be treated to help them gain control of the pain. Diet certainly helps, and I always encourage that they go on an anti-inflammatory diet.
That's good. And I will also refer you to go to Cromwell Hospital website. We have done a whole webinar, 1 hour with gastroenterologist team, with dietitian and everyone to talk about diet and endometriosis. And there are very good points in that chat as well. Thank you.
Is endometriosis fundamentally an autoimmune inflammatory disease?
Many factors. The etiology is still being looked at. Yes. I think the question will come and I see the question down there as well. Retrograde menstruation, where we started this journey from, that can cause endometriosis. We've moved on to immune things. We've moved on to different other theories which possibly can be implicated in the disease of endometriosis, even genetics as well. Even there is possibly genetic link with some transformation of gene mutations which lead to the endometriosis. But do we have one single answer? No. And it's also possible it's a multi-etiological disease. It doesn't have to be one explanation which can explain all forms of endometriosis. It may be inflammatory, maybe genetic, maybe retrograde menstruation. All those factors may play in different types of endometriosis. So I think I will keep my brain side open that we should be just open to all these theories and work on the solutions.
Thank you. This is a more specific question. Someone had pelvic Botox recently for pelvic muscle spasms, saying it's very early days. We're hoping they'll get to the point where pelvic floor physio is more tolerable. How soon after pelvic Botox do you usually recommend trying to engage with pelvic floor physio?
I usually recommend that, they wait at least a week. The reason I say so is when you're doing the injections, the needles go, if you're doing it under ultrasound guidance, they tend to go quite deep through the skin, underlying tissues. Sometimes that can cause pain itself. So usually I try and wait until that tract where the needle has gone through is healed. So I usually give it at least a week, I would say 7 days before they can start pelvic physiotherapy.
Hi, sorry about that.
Yes, Hattie.
Thank you. So there's quite a long question about the prevalence of endometriosis amongst neurodivergent population, especially with some of the comorbidities previously mentioned. And the question comes to do you have any recommendations for how neurodivergent people can navigate pain when some clinicians still might use a traditional pain scale that might not be quite accurate for how neurodivergent people perceive pain?
Yeah, with regards to neurodivergent conditions, I must say that there is emerging evidence now that conditions like ADHD might be associated with endometriosis. The basic problem is that there is just hypersensitivity the nerves that carry pain. And this is usually aggravated by the inflammatory process triggered by endometriosis lesions. And this group of patients tend to feel pain than somebody who hasn't got, ADHD or any neurodivergent condition. With regards to pain scores, I'm not sure if there are different pain scores, for neurodivergent conditions. We tend to use, numerical rating scales, visual analog scales for, assessing the severity of pain. But I suspect we may need to incorporate other pain scores that may look at the psychological element of things, which probably Sharon can touch on a little bit, which would incorporate, neurodivergent conditions.
Sharon?
Yeah, I suppose I've never really faced that question, but I suppose really it would be thinking individually about, what they're experiencing, getting them to monitor it, because everybody has a different level of pain, and different triggers for their pain as well. So I suppose it would be really understanding the person and taking it from them, monitoring their levels of pain, seeing how they feel, So I think that's how you would probably approach it, very individually, and getting people just to monitor their pain, seeing what it is for them.
Thank you. Do you have any recommendations for managing the nausea from the pain induced from endometriosis?
I think usually we use the standard treatment for nausea, things like ondansetron, cyclizine. I would say, the mechanism of action of those drugs should be able to cover any nausea or vomiting that is, induced by endometriosis. So we see that the common drugs that we use to treat nausea, they seem to work for patients with endometriosis as well.
Thank you. Is there anything that can be done to improve migraine and extreme fatigue around the menstrual period?
Like I mentioned earlier on, endometriosis is a very interesting condition. I think in the next few years, we are going to learn quite a lot in terms of research that's being done at the moment. It tends to be associated with a lot of conditions. I know I mentioned 3 so far, which a lot of people might not have heard, of. But there are other conditions like fibromyalgia, irritable bowel syndrome, migraine, temporomandibular joint dysfunction. So it seems like it's a whole, set of conditions where you get the threshold required to stimulate the nerves that carry pain being lowered, and you end up with nerves becoming very, very sensitive to pain, which is why a lot of patients tend to experience severe and debilitating pain.
And the fatigue can also come from the mental exhaustion as well. So it's that constant fighting against it. So again, there's a psychological component to the fatigue.
And how common is it for adhesions to return after surgery?
Adhesions can happen. Any surgery where excision is involved can lead to adhesions and scarring. However, if a surgery is done in the most hemostatic way, which means tissues don't bleed, if there's no unnecessary dissection, precise dissections, and then leaving some anti-adhesion barriers toward the end of the surgery, these things can help to reduce the risk of adhesions. And I think now we believe recently that robotic surgery for endometriosis helps us to mitigate some of these things that I just mentioned.
And this is a question directed specifically at Sharon. Sharon, any advice for someone with ADHD who thrives off stress to get things done, but needs to lower stress to manage endometriosis?
I suppose, it's about just looking at what stress you thrive off and what stress exhausts you, and then finding a nice balance for that. Because it might be that you thrive off work, or you're driven and motivated to get things done in that way. But then there's other things where you can look at where you can maybe stop or or, you know, just reduce the activity in a little bit as well to reduce the stress. Again, individual, we could I can have a little think about it for you too, and maybe send you some more suggestions if you want to send some more detail. I'll also include my email after this as well. So if you do have any questions, I'm very happy to answer you individually.
Thank you. And is leg pain associated with endometriosis?
I mean, absolutely. I think Norma will tell you more. Absolutely can be.
Yeah.
We know that they will talk about musculoskeletal pain, spasmodic pain, the neurological pain, neuropathic pain. All this can involve the leg muscles as well. Norman, you want to add something?
Yeah, not only that, I think I've seen a few patients as well with endometriosis invading the nerve roots as they come out of the spine. So that can give you symptoms like sciatica or radicular leg pain, which is why I'd mentioned that it's very important when you investigate anyone with endometriosis to get an MRI scan of the spine and pelvis as well to make sure that you exclude all these other conditions. So it's very common to get some leg pain.
Thank you. Is there any link between endometriosis and pelvic congestion syndrome, and what treatment can be done for pelvic congestion syndrome?
So pelvic congestion syndrome is an old diagnosis. We don't believe in pelvic congestion syndrome as such, but to give you an example, like people will have varicose veins in their legs when their sphincters don't work, and then they get achy pain in the legs. So the concept was that blood flows into the pelvic area, like uterus, behind the uterus, and this blood pools down and doesn't come out of the pelvis easily because the sphincters don't work very well, valves don't work very well, and that's why pelvic congestion or pelvic pain happens. Now we have changed our mind. We don't think it's a common cause or problem, and it is not being described or accepted as a diagnosis anymore. That's number one. In the past, however, when people used to believe in pelvic congestion syndrome, they used to lift up the round ligaments, application of round ligament, or pulling them up to the abdominal wall, hanging the round ligament with the abdomen just to release the pressure in the veins in the pelvic area. But I said, no, it doesn't happen. However, there is some evidence now, and again, there's a controversy, that when the pudendal nerve is passing through the pudendal canal, there are big blood vessels around that area. These vessels sometimes can dilate, and dilatation of this blood vessel can put pressure on the nerves which are passing through the pudendal canal actually, and that can lead to some kind of shooting pain. But that condition in itself is difficult to diagnose, controversy, and get into that area to then decompress those blood vessels is in itself challenging and full of risk as well. So no diagnosis as yet as a pelvic congestion.
Thank you. I've got two questions that aren't necessarily just about pain, but I feel like they're quite common questions, so I'll ask them. Someone has asked, are you able to advise on the best way to navigate the process of getting diagnosed or a pain management treatment for doctors' consultants? A lot of the time you feel unheard or brushed off.
That's a very good point somebody raised, and I will just offer you to go to two websites, Endometriosis UK and Menstrual Health Project. These are wonderful websites, both of them, that give you a lot of information that when you're going to see a consultant, what you should be asked. I will say, go and see your GP, ask them very relevant question from those websites, that what pain you have, keep your symptom diary, go and ask GP, number one. Two, if you think you have endometriosis because of your symptom you have, then do tell them, don't you think I have endometriosis? Absolutely feel free to challenge them. So hopefully GP will refer you to a consultant, and now a good endometriosis center, BSG approved centers, you have good consultants who can scan you, examine you, and can make a spot diagnosis at that time as best as they can, that if you have endometriosis, and can do further investigation. So yeah, just need to push it, challenge it, ask them, and I'm sure you'll get through.
Thank you. I've put the links to the two charities that you mentioned up in the chat if anyone wants to see. I see someone has put a link up to a previous webinar. That is the correct link. I will try and put the link up to watch the previous webinars as well, so you have that before the end. I think you briefly touched upon the answer to this question, but I'll ask it. This person has an MRI that's showing likely deep infiltrating endometriosis, and they've asked, can they have an operation in their local hospital, or would you recommend being referred to a BSG centre for surgery and treatment?
deep infiltrating endometriosis should be done by a surgically endometriosis trained surgeon. And how you know this endometriosis trained surgeon? The only way you can be certain if he's working in an endometriosis BSG accredited endometriosis center. So I'm very clear about it. You should please get referred to endometriosis BSG referral center, and that's where you'll see the expert who can treat this disease.
Yes, someone has asked for the links of some of the things we've been talking about. We'll make sure that they are included on the email, so you have access to that, as well as Sharon's contact details. Someone has asked, since there can be an overlap between symptoms, like symptoms of endometriosis, maybe referred pain, and conditions like POTS and things like that, how do you know when to stop investigating these comorbidities?
Normal, anything?
Sorry, come again, Hati, with the question?
Someone's asked, because there's lots of overlaps of symptoms and a lot of people have more than one condition, they're asking, how do you know, I guess, when to start investigating other conditions and when to stop investigating other conditions? How do you come to a final diagnosis if there's lots of crossover?
This is where, I said history taking is very important. If you get a good history, 80%, there's an 80% chance of getting the right diagnosis. So when patients come to my clinic, we spend quite a lot of time in terms of exploring their symptoms. I know that my gynecology colleagues would have done, everything they need to do within the pelvis. My role now is to think outside the box when they come in to say what else could be going on here. Why is the pain persistent? Which is why I start excluding, all these other conditions that I mentioned. And then I usually order the relevant investigations to, exclude what I think might be going on in terms of, the MRI scans I mentioned, nerve conduction studies. Sometimes it may be a blood test, for investigations relevant to, mast cell activation syndrome. And then those can be treated, accordingly. So if I do pick up anything that's abnormal, usually I would refer them either to, say dysautonomia specialist if there's issue of dysautonomia. If it is mast cell activation syndrome, I'll refer them to an appropriate specialist. And usually they put them on a course of antihistamines, which sometimes can just settle everything down and reduce the sensitivity of all the nerves that carry pain within the pelvis. But this will be alongside the pain management plan that I would have already put in place, so that we got a holistic approach and we're covering all aspects of, what could be triggering the pain in this group of patients.
There's been a few questions on this. Apologies if I do not pronounce it correctly. Someone's asking your opinion on the newly released endometriosis drug in the UK, Rayco?
Yeah, absolutely. Yeah, Rayco is good. You can absolutely be given for your consultant first, and then GP can continue and maintain them. Rayco is a medicine which has, number one, it blocks the estrogen. Number one. Number two, if you block the estrogen, you may get hot flashes, night sweats, because endometriosis is an estrogen-driven disease. So by blocking estrogen, we can help relieve the symptom by stopping periods, but then side effects of estrogen blockage can come. And this Rayco has built in a little bit of estrogen in it as well, along with progesterone, and that helps that to have side effects. So Rayco is absolutely fine. It can be taken for deep infiltrating endometriosis, also for fibroids as well. So consultants can start and GP can maintain as well. So yes, it's a recommended medication.
Thank you. Someone has asked, is it better to have excision surgery before freezing eggs or after?
That's a very good question, even though it should come into fertility. So you should listen to a fertility webinar. We're doing all these things now. So I'm sure one of my colleagues will put the fertility webinar thing, and you will have absolutely wonderful discussion by our colleague Kate McLaren, who is expert in endometriosis and fertility, to talk more about this one. So my question is, there are tests which needs to be done before the operation. And if the AMH is low, and if you have ovarian endometriosis, then best is to have egg freezing first. And also I should add as well, as most patients could be in the NHS has a policy which I don't agree, but the policy is that if you had a surgery done, they won't offer you egg freezing service on the NHS. So again, if you're having endometriosis and both ovaries involved, then ask your NHS first if they can do egg freezing before you go for the operation, but this is not that simple, because sometimes they may not be able to collect eggs because of severe endometriosis. So question comes, a chicken and egg story, but this is a discussion you need to have with your consultant and your local NHS trust to give you the right guidance.
Thank you. Is burning pain usually an indication of nerve pain rather than coming from endometriosis?
Norman?
Yes, burning pain is one of the symptoms, that indicates that you've got neuropathic pain. Remember that we mentioned that with endometriosis, you've got these lesions that are outside the uterus that are invading the surrounding tissues. So sometimes you get these lesions around the nerves themselves, or even peripheral, very small nerves, where they affect the way the nerves work, and eventually they become very, very sensitive. So you tend to get this burning sensation, which is part of what we call neuropathic pain. So it's a sign that there is some degree of nerve damage, which is why we would consider medications like gabapentin, pregabalin, amitriptyline, or duloxetine to try and alleviate that burning sensation, because these medications try to reset the nerves to get them closer to normal as much as possible. So I would agree that burning pain is clearly a sign that there is a neuropathic component to the pain.
I agree. If burning is one of the symptoms, then neuropathic pain should be seriously considered as one of the indications of that pain. Yeah.
We have quite a few questions left, so just to check in on time and see how many might still like to be asked.
We can go for another 5 minutes. Is that okay, Norman and Sharon? Is okay?
Yeah.
Good for
Let's carry on quickly. Yeah.
Okay. Some of them are now quite specific about people's personal experiences. So this person's been diagnosed with endometriosis, has PCOS, has chronic pelvic pain daily. Their infection markers are very high, and they're wondering if there's a way to confirm whether the inflammation markers are related to endometriosis or something else, to rule out anything else going on. So they're asking, is there a way to test to confirm that, or would inflammation show on an MRI scan?
Inflammation per se, for endometriosis has to be diagnosed in its own right, which means patient have examination history. In the last webinars, we've talked in detail how to diagnose endometriosis and what to look for. So that will help you with diagnosing endometriosis. Inflammatory markers going up, the only inflammatory marker we know is a tumor marker called CA125, which we do normally in the clinic. If I see an endometriotic cyst, I will do a CA125 and it's found high, but it's a tumor marker, not really as such inflammatory marker, so it can go up in number of inflammatory conditions that can help you. But again, it's not diagnostic, it's just indicative of or suggestive of. You still have to do all the tests to diagnose that problem. Yep.
Thank you. Someone's saying amitriptyline makes their tinnitus unbearable. Is there any alternatives to that drug?
Okay. The other option is, I don't know whether they've tried nortriptyline or duloxetine, and also, pregabalin, gabapentin could be tried as well. But the most important thing would be to try and find out, is that tinnitus really, secondary to amitriptyline, or is there something else going on? So I would work closely with an ENT surgeon to get that investigated appropriately, and to also change, the medication at the same time. But we do know that it can cause tinnitus, yes.
So this person says, thank you for your time. How can adenomyosis and fibroids affect the symptoms and treatment of endometriosis? Where does one start and the other end?
That's a good point, because adenomyosis, fibroids, endometriosis are estrogen-driven disease. And for adenomyosis, there's a lot have been written now. It's been very poorly diagnosed before, but now we are talking more about it. And adenomyosis could be diffuse, the whole uterus involved, could be focal. If it's a focal adenomyosis, meaning a lump, then surgically it can be completely removed, which will help your symptom as well. If it's a diffuse one, the only solutions are medical hormonal treatment like Mirena IUS or progesterone, Dynagest, Ryco, all those things will be fine as well. And when it comes to fibroids are fibroids. If they're small, asymptomatic, no matter, doesn't matter, no need to do anything at all. But again, I think there's another webinar on fibroids we have done as well. Check that out, because different fibroids can have different implications from fertility to pain and symptom, and management has to be tailored according to those fibroids and their symptoms.
Thank you. Someone has very bad lower back pain and has endometriosis and is wondering if they're connected, and also if there's any treatments that you would recommend. They've not been recommended physiotherapy yet, so they're also wondering if that might be an option.
Norman?
Yeah, I would definitely start with physiotherapy, because we know that it helps a lot of patients. And the next option after that, if physiotherapy is not helping, will be to get an MRI scan of the spine and pelvis to see whether there may be, some lesions from endometriosis around the spine. If not, it may be that, some of the discs in the lower lumbar spine might have prolapsed. We know that some of the discs in the lower lumbar spine, when they prolapse, they can be associated with pelvic pain as a referred pain, which normally comes to the groin or upper thigh as well. So definitely would need to do further investigations to see whether, the endometriosis is related to the back pain or it's separate.
And just adding to that as well, endometriosis is about pelvic pain. It means pelvic muscles are being congested, they are being very tight, and then tightness of pelvic floor muscles can also lead to backache as well. When we looked at most common symptoms for endometriosis, backache was present in about 40% of the patients. So backache is also one of the common symptoms for endometriosis, either directly because of endometriosis, nerve-related lesions, which Norman just mentioned, or could simply be muscular spasm as well because of endometriosis.
I'm aware of the time. Would you like another question?
Yeah, I take one more question, then we'll say thank you then.
This one again is relatively specific. Can perimenopause be exacerbated by endometriosis?
We know that is estrogen-driven disease, so we expect and hope that as we go toward the menopause, symptoms should settle down and calm down, not get worse. No, it's unlikely. Even though I've seen recently a number of patients who came to us around this perimenopausal period with their symptoms have returned or their first time being diagnosed, but it's uncommon. Usually I will expect symptoms to get better at this time.
Thank you. There was also quite a lot of questions about menopause, asking if it resolves at menopause. So I think you've answered quite a few people's questions over across menopause as well. Would you like a further question?
I think I will just say no. I think what you can do now is please send the questions to us, and we and Denia will try to answer as many questions. But I would like to say in the end, thank you very much for all of you who are joining us for so many webinars now. We have talked about the bowel, we have talked about physio, we talked about diet, we talked about a urological problem as well in these webinars, and today we touched on pelvic pain. We are going to come back to you and talking about something very important to so many of you is painful intercourse and how endometriosis can have a severe impact causing dyspareunia, painful intercourse, superficial vaginismus, all those problems which lead to huge personal relationship and issues as well. And there's a very little help you can find around it as well. So we're going to come back to you very soon. Thank you very much for all of you coming, supporting us as well. And I'm sure we'll keep working together to make things better and make the services better for endometriosis.
Thank you very much to our panel. I'm just going to put up a slide which shares some of our information for a few minutes in case you want to take that down. It's also in the chat, and there's lots of lovely thanks coming through on the chat as well. So thank you all very, very much.
Thank you very much.
Thank you.
Thank you very much.
Thank you very much. Bye.
Thank you, everyone. Thank you all for your notes as well. We'll try and put as much of that information and links into the email that gets sent tomorrow.
Yeah, that's good. Lots of thank you coming in. That's very nice. Very good of them. It's closed. No, it's open.
Thanks. Maybe
Hattie, when we send the email with the webinar, maybe we can send a link to the other webinars as well, which we have done before.
Yeah, I think it might be a good idea. I think it might be to just incorporate everything all in one place.
Yes, of course. Thank you, everyone. I will now close the event and put as many links as possible in the email that you will all receive later. Thank you.
Thank you very much. Thank you. Thank you very much. Thanks, Norman. Thanks, Sharon.
Thank you. I'm sorry about that. My laptop just dropped out, so I apologize. Thank you.
Thank you.